Well, good evening, ladies and gentlemen. There may be people who straggle in, but we'll go ahead and get started. For many years, we've been doing high-intensity focused ultrasound outside of the United States because it was not yet approved by the FDA. Once FDA approval was obtained in October of 2015, I set up a site in San Francisco to make it easier for patients to fly in and out, and that is our closest center. There are also centers associated with HIFU prostate services all over the country, and more sites coming up every day. The designation of HIFU Center of Excellence was something developed by Sonablate Medical, the manufacturer, one of the representatives of which is here in the front row, and that designates a location where a physician is qualified to teach the procedure. I'm a four-time board-certified urologist here in Santa Rosa. I've been here for over 30 years now, and got interested in HIFU back in 2007. At that time, I began taking patients to Toronto and then to Puerto Vallarta, and we developed our techniques and treated American men in these locations until the FDA approval in October of 2015. It is nice not to have to travel so far now. HIFU stands for high intensity focused ultrasound, and the focusing is the key. We frequently refer to the magnifying glass outside burning a hole in the leaf, as most of us did when we were kids. And as you know, if you have a magnifying glass and you shine the sun through it and it's in a wide circle on your hand, you won't feel anything. If you focus the magnifying glass to where the light is to a point, it will create heat and burn, much as this leaf on the screen. The ultrasound energy is emitted from a curved source, and all of the sound waves come out in a straight line. So along that curved source, they all go out and they intersect. Where they intersect with ultrasound energy, heat is created, and that is the energy that we use to kill the tissue. Each time the machine fires, a lesion that's 3 millimeters by roughly 10 millimeters is created, and it is placed in the area of interest in the prostate with imaging ultrasound that we use. And we literally fill the region of interest with these shots until they're all treated. The prostate can be treated in portions or in the whole gland. Up until about 5 years ago, all of us treated just total gland, but now there is emerging research which shows efficacy for treating portions of the prostate. The benefit to the patient is less side effects. This picture shows the source of the ultrasound, which is called a transducer, and it is placed in the rectum near the prostate. The prostate is depicted as this blue object here. And then within the prostate, there are zones of treatment where each of these little shots is pointed. The procedure begins by placing the probe in the rectum. The pertinent landmarks are all imaged, and then we plan the treatment zones in the prostate, usually an anterior or front zone, middle zone, and then the posterior zone near closest to the rectal wall. The treatment is outlined, the shots are administered to all the places that we have of interest, and then the procedure ends at that point. This again shows the probe in the rectum. This pear-looking object is the prostate with the urethra going, and I'm not sure what fruit this is, but that's your bladder, just to give you an idea of position. When we look at the screen during the treatment for planning, we see the prostate in multiple views. This is viewing as if the prostate were sliced straight up and down in front of you. This is if you slice the prostate from bottom to top and then looked at it from the side. And then this is looking down on top of the prostate as if it were below you. And these little red dots, we call them skittles, are where the shots will be given. And as you notice, we are able to provide a halo of treatment around the prostate. So in those multiple tumors that show probability of perforating through the capsule, most of those perforations are only 1 to 2 millimeters. And so with this technology, we can create the halo to get those lesions. Tissue change monitoring was a monumental advance in this technology. When we're doing the procedure, we're mainly watching and adjusting based upon this view, and this is a blow-up of that picture. And each one of these stripes is where the machine is going to fire. These have already been treated, and as you can see, they give us colors of orange, yellow, or green. The way that the machine determines these colors is that before it fires the energy into the prostate, it sends a radio frequency signal into the prostate and then fires the energy and then sends another radio frequency signal in. And the difference between the feedback from those two signals tells us how hot the tissues got during the treatment. So if a treatment shot comes back orange, we know that we're at least 80 to 90 degrees Celsius. If it is yellow, we're above 70 degrees Celsius. And if it's green, it's probably below 60 degrees Celsius and has to be retreated. Tissue dies at 60 degrees Celsius in 1 second. So if you're getting a yellow or an orange feedback, then you're well above the temperature needed to affect the treatment. This is an MRI of a prostate that's been treated, the total gland, and this tissue is completely dead. And over time, it will slough into the urinary tract or get reabsorbed, or the scar tissue will contract it down and it'll be much smaller. More recently, we've advanced beyond just treating the total gland and now can treat portions of the prostate. And this has been a boon for urologists and patients alike. In the past, we treated the whole gland, and we still do if the cancer, as they're showing here, is in both sides of the prostate. But if the cancer is only in one side, we might choose to treat the one half of the prostate. Or if it's tiny and located in one location, we'd only treat a portion of one side of the prostate. And the results of these treatments are turning out to be very good for cancer control and extremely good for prevention of side effects of treatment, particularly incontinence, erectile dysfunction, etc. So this places focal HIFU ablation right in between where we've been all this time. Till this point, we only had active surveillance for the low-grade prostate cancers, and if the cancer was more aggressive, then we went on to surgery or radiation. This technology applied focally allows us an in-between choice. The active surveillance protocol requires that patients have repeat biopsy sessions after 1 year and then every 2 to 3 years after that. Patients very much dislike biopsies, and biopsies are becoming more prone to cause sepsis because the germs are getting smarter and the antibiotics that we give may not be able to prevent an infection. And so it's desirable to have a path where you don't have to have repeated biopsies and yet still give a definitive treatment to control the cancer. The ideal patient for HIFU is the same patient who is ideal for radical prostatectomy or radiation therapy. That is, usually PSA less than 10, Gleason score up to 7, prostate volumes that are not too large, usually up to 40 cc's, which is a medium-large prostate. But there are certainly patients that we treat that have PSAs above 10, that have Gleason scores 8 or 9, and they do well. It's just that, like with surgery and with radiation, they don't do as well. That is, there's a higher risk of recurrences in those more advanced cancers. HIFU can also be used to treat recurrent cancer. So if a patient has radiation and the cancer comes back and it's found to be localized to the prostate, then we can treat them with HIFU. Cryotherapy, where you freeze the prostate, same thing. Brachytherapy, where the radioactive seeds are placed within the prostate, is also amenable to treatment with failures. With radical prostatectomy, if there is a very well-defined nodule in the bed of the prostate near the bladder, we can target that and treat that too. But that's not done very often. And unique to HIFU, if you have HIFU and require additional treatment, you can still have another HIFU if you want to, or you can have surgery or radiation. You haven't burned any bridges with the choices, and that's a very attractive feature. The HIFU procedure is a 1.5 to 4 hour procedure based upon how large the prostate is and how much of the prostate you desire to treat. And the machine treats 3 millimeters at a time, which is a tiny little place, like a site like a grain of rice. And so, as you can imagine, a larger prostate is going to require more shots and more time to treat than a smaller prostate. A total gland is going to take longer than a partial gland. Regardless of which is done, this is an extremely well-tolerated procedure. Patients have it done under general or epidural anesthesia. There's a 1 to 2 hour recovery time at the facility, and then they get up and go home. You go back to normal activities very soon. HIFU is painless and bloodless because the HIFU energy seals the nerves and the blood vessels, very much unlike surgery and radiation. As we said, HIFU is usually a one-time procedure, but it can be repeated. Patients who have had HIFU will have a catheter in for 1 week if a focal therapy or half the gland is treated, and if the total gland is treated, the catheter may be necessary for up to 3 to 4 weeks based upon the swelling that occurs and how it compresses the urine channel, making it more difficult to urinate. As that swelling resolves, then patients are able to go back to normal activity. Our follow-up is merely doing a blood testing with PSA and a digital rectal exam every 3 months for a year and then every 6 months. All treatments can have side effects, and fortunately with HIFU, the side effect profile is lower than for any of the other treatments. The total list of side effects can be obtained from Sonicare Medical, and we don't need to have a list of the very rare side effects that have been sustained in this talk. The results, this chart was produced by a third-party clinical review organization, and these are low-risk patients. These are Gleason 3+3, PSA less than 10, and smaller tumors. The FDA seemed to want to compare apples to apples with surgery, radiation, cryotherapy, and HIFU, and so they decided for the earlier studies that they would be on these types of patients. Now, many of these patients are candidates for active surveillance and might not choose to have treatment done. But if they did, this is what the results would be. As you can see, the risks listed are the potential side effects, and the ones that mainly are encountered are incontinence and erectile dysfunction. And so for total gland treatment, you have an incontinence rate of only 0 to 2%, and that's mild incontinence. It's usually only drops of urine. It's very, very unusual to have a patient leaking large amounts of urine. Erectile dysfunction with total gland is somewhere between 10 and 20%. Now for focal therapy, because we don't have to treat as much of the prostate and expose as many of the nerves to the heat, the continence profile is significantly improved. And the remainder of the different treatment modalities you can read there. I apologize for this slide. The Sonicare Medical wanted to put 3 pages of a paper on one slide, which is almost impossible to do. But what's important to know from this is that these patients were not those 3+3 PSA less than 10 patients. These were aggressive tumors for the most part. Intermediate risk and high risk comprised 87% of all the patients that were treated in this study. And these were not just tiny tumors. There were tumors that were up to stage T3, which is the whole prostate extending toward the takeoff of the seminal vesicle. That's a lot different from that little isolated nodule that we talked about. But even with these higher risk patients, the study performed on patients treated from 2004 to 2015 shows remarkably good results. As you can see, in this study, the urinary continence rate was 97% and 98% at 1 to 2 and 2 to 3 years. Continence with pad-free, leak-free reflects the few drops that may come out, which may prompt patients to use a liner. Generally, pads are not necessary. Erectile dysfunction, in this study, there was return of function in 84 to 86%. There were some recurrences in field, meaning that just where you treated it, that cancer came back there. 29 out of 222 that were biopsied, and remember, there were total number of cases treated actually was 625. Out of field recurrences are places that were not treated but developed cancer later on in other parts of the gland. And then there's the combined incidence. I apologize for this slide, Karen. This will not, please do not tell people this has not been released yet to the public. It'll be presented in May at the American Urology Association meeting. But this is, the key in this is that these are patients that were treated from 2009 to 2016. So the previous study was 2004 to 2015, but what this shows you is that we learned a lot between 2004 and 2009, and that continues to improve now. So at this point, you've got the same intermediate and high risk patients that at 5 years of follow-up, the overall survival was 100%. Metastasis free, meaning the cancer had not spread anywhere, was 99.4%. And significantly, only just under 10% of the patients needed to have any treatment over and above the focal therapy. That is remarkable for this subset of patients. So out of 164 patients, only 16 needed additional therapy, which is truly impressive. Notice that we learned how to do things a little bit more efficiently and safely, so now 100% urinary continence. And I will tell you that this 82% number no longer exists either. In patients treated in the last 3 or 4 years, that the erectile function return is better than 90%. I started treating it, as I said, in 2007. I deal in full gland primary and in focals, and have done salvage treatments. I was one of 3 proctors for the FDA HIFU study, and that was a study purely doing HIFU on salvage patients after radiation failure. Eventually was made the Puerto Vallarta medical director for Sonicare back when we were still treating out of the country, and currently am medical director for HIFU Prostate Services, which is a national company based out of Charlotte, and some of their employees are here right now. HIFU has been around all over the world before the United States finally had FDA approval. And so there are 100 centers outside the United States, maybe more now. Karen could probably give us better numbers on that. There have been over 15,000 patients treated with this technology. And in the US, our company, HIFU Prostate Services, is treating just under half of the total cases done in the country. Thank you for listening. Questions?
Does some of the numbers that you've given in terms of success rate include the European or the outside of the United States?
So the question is, do the numbers that we presented include the European studies? Yes. The first slide that I showed with the patients treated, 625 patients treated from 2014 to 2016 were British. It was a British study. The unpublished data is also a British study. Yes, sir.
Is salvage treatment, are your salvage treatments confined to the prostate?
Yes, they are. HIFU energy is like surgery and cryotherapy, where everywhere it touches, the tissue dies. So we cannot go treating prostate cancer in other parts of the body because we'll kill the organs where those prostate cells are. Any other questions?
The treatment itself, besides the sensation of the rectal probe, is there heat or discomfort?
The question is there heat or discomfort after the treatment? Well, during the treatment, patients are under anesthesia. So yes, there would be pain, but the actual heat energy seals the nerves and blood vessels so that when the patients awaken, there's no pain or bleeding. They do feel the catheter, but that's separate from the prostate treatment. All right, well, thank you very much. I appreciate your attention. Thank you for braving the night and the aftermath of the elements that we've been sustaining. We'll be happy to answer any other questions. And again, if you'd like more information, please sign up at the back and we can give you additional materials.